this new center. So this webinar is being organized by Koita Center for Digital Health, which is one of the new centers on IIT Bombay campus. So the center offers programs on digital health, masters, PhD programs, dual degree programs, and so on. And the focus of the center is on digitization of health, both healthcare services, delivery, healthcare records, and so on. So Dr. Pramesh has been a big supporter of this center right from the beginning. He is on the advisory board of the center. And he has enabled lots of collaborations between here and Tata Memorial Hospital. So first of all, let me give the formal introduction. Dr. Pramesh is the director of the Tata Memorial Hospital and a professor and head of thoracic surgery at Tata Memorial Centre at Mumbai. His clinical interests include the management of esophageal and lung cancers. He is the PI on several projects, clinical trials, surgical techniques, and his broader research interests include cancer policy, health equity, value-based care, and health services. He has more than 200 peer-reviewed journal articles to his credit and several national and international awards. He is the convener of the National Cancer Grid. He has strong interests in clinical trial design, surgical trials, comparative effectiveness research, and so on. So I'll not take too much of the time. I would welcome Dr. Pramesh to this virtual meeting at IIT Bombay and request you to deliver your talk.
Thank you very much, Professor Bangikar, and I'll take this opportunity to thank Professor Ganesh as well for the kind invitation to speak at this session. So what we've been doing with the Koita Center for Digital Health is really exciting, and I'm hopeful that in the years to come, we really expand on the scope and the scale of what the center will embark upon. And I'm really privileged to be a part of its advisory board. So what I thought I'll discuss with you today is something that's that we've been working on over the last decade, which is on reducing disparities in cancer care. And this is more or less, I'm going to be sharing a story with you, the story of how the cancer grid evolved, how it developed, and what it has done over the last decade or so. So to understand this, we need to go back almost 12 years back when the Tata Memorial Centre in Mumbai was had just two centers, which is the one on the left, which is the oldest center, part of the hospital, which is the Tata Memorial Hospital in Parel, and our relatively newer center in Kharghar, which you see on the right, which is the research facility. And we were de facto the oldest, the largest, and known globally for high quality patient-centric care, as well as education and cancer research. And we had quite easily taken on the tag of being the best cancer center in the country. A year or two later, we looked at this heat map. What we did was to interview 75,000 patients who visited the Tata Memorial Hospital over a 6-month period, and we geotagged what their geographic location of residence was. And this was the heat map that we were able to produce. And you might assume that it's very normal for this very dense population coming from Mumbai and the state of Maharashtra, which is approximately just under 40% of all of our patients who come to the hospital. But what was very disturbing to us was this very high density of patients coming in from the north, the east, and the northeast part of India. And as many of you know, the distance from, say, let's say, Naharlagun in Arunachal Pradesh to travel to Mumbai could take you easily up to 2 days. And this was even if you were taking flights and not just by train. And added to this is was the huge expense of staying in a city like Mumbai, the accommodation and the food, and the strangeness of taking cancer care in a very distant location from where you're when the patient's home were. So as I mentioned, 85% of our patients are from outside the state of Mumbai, 60% from outside Maharashtra. We had a substantial proportion of international patients. We were a very busy clinical practice, including having fairly long waiting lists for treatment with a 100% bed occupancy. So from this point to when you were faced with a dilemma like this, we needed to think on our feet as to how we could address this problem. And one of the initiatives which the government of India took, which tried to address this problem, was to ask us to start more hospitals within the state, within the country. And we were asked to start cancer hospitals in Punjab, in Varanasi, in Visakhapatnam, and take over an existing cancer facility in Guwahati. So while this might work to some extent, we were also faced with this quite sobering statistic, which was that the incidence of cancer was likely to go up by almost 70% in less than 2.5 decades. And added to this were geographic inequities in access. And very obviously, most of the some of the best centers for cancer existed in the south and to some extent in the west. Whereas when you look at north, central, and east India, the overall metrics which you look at for the provision of cancer care were fairly limited, and these include radiotherapy centers, oncology departments, and as a measure of population, it was woefully inadequate. We also are aware of economic inequities in access and the challenges of healthcare financing in India. We are all aware that just 1.5% of our GDP is spent on public healthcare expenditure, with the result that over 70% of healthcare expenditure is from out-of-pocket expenses. And it does shift a substantial number of India's population below the poverty line purely out of healthcare expenditure. So just to give you a context on public healthcare expenditure on healthcare, we'll compare two countries which are both Commonwealth countries. Canada spends approximately 11.6% of their GDP on health, whereas India spends 1.5%. The GDP of Canada is over $45,000, while the GDP of India is just under $2,000, which means that the per capita healthcare annually, public healthcare expenditure is $5,200 in Canada compared to just under $30 in India. The infrastructure gap is also something that is fairly concerning. With some of these metrics, this was an Ernst & Young report which came out 7 years back, which looked at surrogates of provision of cancer care, which is the total number of radiotherapy equipment and linear accelerators, the dedicated cancer beds, the number of comprehensive cancer centers, and the human resource to treat cancer in the country. And as you can see, even without the even assuming constraints of affordability and access, the estimated requirement in 2020 was is listed in this column. Whereas if you look at the estimated number, the current estimated numbers in 2015, they were anywhere from 1/2 to 1/3 of what the bare minimum needed to be. And just to again bring this into context, the Tata Memorial is sister institutions with the MD Anderson Cancer Center in Houston. And we are remarkably similar in many ways. We see almost the same number of patients annually. MD Anderson sees 42,000 and we see 46,000. And while the MD Anderson has 1,700 physicians and researchers on their faculty, we have just 188. So clearly bringing the stark differences in resources, both by way of human resource as well as infrastructure in public cancer centers in India. And when you're faced with a graphic like this, and including the plans of creating new hospitals, these are clearly not adequate to address this problem, which is a far bigger problem than what you would assume it to be. So we needed to think of something fairly disruptive to leapfrog over a conventional way of expansion, which is building new cancer centers and expecting them to serve the needs of the population. And that was the birth of the National Cancer Grid, which we conceived as a network of cancer centers across the country. When we started the Cancer Grid almost 10 years back to the date, we conceived this as bringing all the regional cancer centers in India, which at that time were 29 in number. And the three pillars on which the NCG was founded was to try and work towards uniform standards of cancer care, thereby negating the need for patients to travel thousands of kilometers to access high quality care. We also thought it was important to develop trained human resource to bridge the gap in oncologists to treat the increasing burden of cancer. And finally, to also serve as a collaborative network for multicentric cancer research, which were relevant and context specific to the country. We did anticipate several barriers and hurdles, and this is probably why efforts like these had never succeeded in the past. It wasn't for lack of initiative. The first and foremost that being that collaborations were fairly immature in the healthcare sector, and especially with cancer care, where healthcare providers were more in a spirit of competition rather than cooperation and collaboration. And this was something completely alien to the healthcare situation in India. There was also the fear that by virtue of being the oldest and de facto the National Cancer Centre, whether we would be considered as big brother trying to dominate all the other centers into following our views. The next hurdle was fear. We emphasized on quality a lot, and we wanted quality of all centers to be more or less equal, which always raised the concern amongst some of the smaller, less resourced cancer centers, whether their quality gaps would become public and give them a bad name. There was also this overriding concern of what's in it for us? What were the benefits of getting into a network like this, and why should we waste our time and efforts in joining in this kind of a network? And the sheer logistics, as I said, something like this had never happened in any healthcare sector in India. And the sheer logistics of getting a large number of cancer centers together and agreeing on common terms was fairly daunting. And finally, as many of you might agree with, there's a lot of skepticism about whether efforts like these will work. I think most of us have been in enough meetings to understand that while we discuss a lot of very grand plans, very few of them actually get implemented. And there's always this sense of skepticism about whether, especially an initiative as ambitious as this would really work. Nevertheless, we took our first plunge in August of 2012. We invited the 29 regional cancer centers for a meeting in Mumbai to discuss how we should approach creating this network and what the future vision of this network would be. And as I mentioned, the skepticism ended up with just 17 of these 29 regional cancer centers participating in this meeting. But nevertheless, it was a reasonably good start to this effort. One of the first areas that we undertook was the fact that the data was scarce, and therefore we needed to first identify the gaps that we had, both with the with the burden of cancer, what our national priorities should be with cancer research, but most importantly, what were the challenges and what are the possible solutions towards the delivery of affordable and equitable cancer care in India. And we brought this out as a series of commissions which the Lancet Oncology commissioned. I did mention earlier on that uniform cancer care was at the heart of where the cancer grid functions. And one of the early activities that we undertook was to have consensus treatment guidelines which are specific or context specific to the situation that we are in India, given the resource constraints. But what we realized very quickly after we brought on this first set of guidelines was that evidence base was one thing, implementability and cost effectiveness were something entirely different. And therefore, we did this study with some of our colleagues in Canada, where we looked at two of the world's top oncology organizations, the American Society of Clinical Oncology and the European Society of Medical Oncology, both of whom had come up with what they called value frameworks to evaluate whether new interventions in cancer were worth the money that we were spending on them. And soberingly, I'll take a minute to take you through this graph. What we realized was that, so let me explain this graph first. So the ESMO value framework is a dichotomous framework. So it either calls something value for money or not value for money. So the blue bars are the interventions which did not meet the ESMO benefit threshold and therefore are considered not value for money. Whereas the ASCO value framework has a value score attached to it. So higher the score, which means the taller these bars are, the better value for money they are. And as you can see, even two of the value frameworks, which while there is some agreement in the low value areas on the left of this graph, there is virtually no agreement between these two major oncology organizations' value frameworks as what they considered value for money. So if Europe and America couldn't agree on this, it's highly unlikely that low middle income countries like India would find these value frameworks useful. But what surprised us in this study was this remarkable conundrum where cost had nothing to do with benefit. While you might expect that the more expensive an intervention, the higher the benefit, what we saw was not only was there no correlation, there was actually a negative correlation, which meant that you actually spent more on less effective treatments than on more effective treatments. So there is no logic or rationale to this. The cost of a treatment is what the market can bear and not necessarily based on the benefit that it accrues to, in this case, the consumer, which is the patient. So one of the first activities we wanted to do was a robust health technology assessment program. And any of you who worked in health economics and health technology assessment realize that this is a very formidable effort to undertake. And while countries like the UK and Thailand have done a great job of doing robust health technology assessment, the lack of resources within India meant that this was a very fairly long-term project. And therefore, we took a conscious decision that we would have some quick wins, which we did through choosing wisely. And I'll explain what choosing wisely means. But we also parked health technology assessment as a more longer term goal, which I'm happy to say we have subsequently initiated. But a couple of years back, when we wanted to look at low value practices, what we thought would be more expeditious was to identify common practices which were either low value or harmful, and that those should be that should be avoided in cancer care. Now, you must understand that in a largely unregulated healthcare environment like what we live in India, this is not something that is easy to push. Nevertheless, we did work with key opinion leaders in oncology in various roles, both from the public sector as well as the private sector, the leaders of oncology associations. And finally, we were able to come to a consensus on 10 points that we recommended should be avoided. And if you look at it, even for those of you who are not medicos, these are very, very straightforward recommendations. If you look at this, do not treat patients with advanced metastatic cancer in the intensive care unit unless there is an acutely reversible event. So some of you might wonder why this needs to be even spelled out, because given the resource crunch that we have, you would want every intensive care bed to be used for patients who are likely to derive large benefits out of it. But the fact that this needed to be spelled out means that these are practices which are very common and practiced in large parts of the country. The next aspect that we took on was to modify our initial version of the guidelines into what we called resource stratified guidelines. So this is now online, and it has been online for the last couple of years now. So what we did was to convert this fairly unidimensional initial version of the guidelines into 3 categories. The first, which we called essential, which meant that if a cancer center or a hospital did not have facilities to treat with these essential guidelines, they should be referring the patient to a higher center. The optimal, which does take the essential as a bare minimum, but also adds on some desirable elements of cancer care, which might reduce patient morbidity and complications and are proven to be cost effective. And finally, the optional, which means that we have no concern for cost, so long as there is benefit, these could be, and they're evidence-based, they could be followed. So what we are strongly suggesting is that public healthcare money should be used primarily for the essential and the optimal guidelines, whereas if somebody is super rich, they could opt to take the optional guidelines. And I mean, very, very serendipitously, what happened was when we released these resource stratified guidelines, we had the then deputy CEO of the Ayushman Bharat program as a special invitee for this meeting, and he, without hesitation, adopted these essential and the optimal guidelines as a prerequisite for reimbursement under the National Health Authority PMJ scheme. So while we did not intend this to be a regulated implementation of guidelines, the serendipity worked to our advantage, and now cancer is the only healthcare area within the Ayushman Bharat where reimbursements are actually linked to adherence to these guidelines. Quality is central to everything that we do within the cancer grid. So we started this process of institutional peer review, and this stems from a previous experience that we had at the Tata Memorial, where we had an international group of over 20 experts from various specialties spending 6 months of email exchange, followed by a 3-day site visit at the Tata Memorial twice, first in 2010 and the second in 2016, where they came in and looked at the strengths, the weaknesses, and the gaps that we had, and came to us with very concrete recommendations on how we could improve our performances. And we extended this to the cancer grid, where voluntarily institutions could apply for peer review. We have a similar process of data exchange of metrics, quality metrics between the centers and the expert group. And a team from the NCG centers then visited these centers, had a site visit, and came out with a peer review report. And what the centers realized was that this was not a fault-finding exercise, but more an effort to improve processes and systems within these organizations. Again, quality is central to diagnosis. Surgical pathology quality assurance programs are in place. So the most well-known amongst them is the College of American Pathologists accreditation system. The Tata Memorial does subscribe to this, but anyone who's been through this realizes that it's an extremely time-consuming, effort-intensive, not to speak very expensive process of accreditation. So what we did was to start a leaner, meaner version of the College of American Pathology accreditation system, and we offer this now online through a digital web platform, wherein we compare reporting quality of pathology, which, as all of you know, is central to a cancer diagnosis and subsequent treatment. Based on this success, we have expanded the scope of pathology equals to molecular pathology. As you know, molecular pathology is rapidly making strides in cancer treatment and is at the center of precision medicine and personalized medicine. So we are the only organization in the country which offers molecular pathology quality assurance programs for cancer. In addition to these specific areas like pathology, we also have worked on a quality improvement program for institutions. This is in collaboration with the Stanford University. And what started off as a handful of centers getting in for quality improvement programs, we're now rapidly expanding with anywhere from 8 to 12 centers every year getting onto a quality improvement program. So all of us realize the importance of getting an expert oncology opinion. However, many remote places do not have expert oncologists, and they still have to do with whatever opinions they get from their respective physicians. So what we did was to enable these patients to share their reports in a secure platform with a backend tech firm called Navya, with whom we partnered. And the backend folks at Navya put the reports, including DICOM images of CT scans and pathology reports, onto a structured format, send these reports to a National Cancer Grid or a Tata Memorial expert, who then feeds back their opinion, which is then translated in layman's language back to the patient. And all this that I described happens in a median turnaround time of just 24 hours. So what we thought would be an India-centric initiative has now become global, given the ubiquity of having internet access. So currently 48 countries, patients from 48 countries, over 35,000 patients have accessed these treatment decisions. And you might expect that the vast majority of these 48 countries might be low middle income countries. Surprisingly, we had patients from 23 high income countries accessing these expert opinions, clearly demonstrating that the need for an expert oncology opinion is not limited to resource constrained settings. All of us who work in oncology realize the importance of a multidisciplinary team approach. So there's enough data to suggest that patient outcomes are superior if the decision is taken by a multidisciplinary group rather than an individual clinician. There's this really elegant study coming out of the United States, where a clinical situation with prostate cancer was shared with medical oncologists, radiation oncologists, and urologists. And an equally high number of close to 80% of surgeons felt surgery would be the right treatment for that particular clinical situation, whereas 80% of radiation oncologists felt that radiation would be the best treatment. So it clearly goes on to say that if you're operating as individuals, it really doesn't benefit patients at least for cancer management. But the reality is that many of the smaller centers lack the bandwidth to be able to have site-specific working groups. So, for example, at Tata Memorial, we have a separate working group for lung cancer, a separate one for breast cancer, and so on. Whereas in some of the smaller centers, you might just have 2 or 3 oncologists handling the entire spectrum of cancer. So the ability to specialize is limited, which means that the ability to discuss these patients, many of them who have complicated clinical situations, in a multidisciplinary group which has the expertise to do so is fairly limited. So we started using web-based virtual tumor boards, and we did this long before COVID struck us. We started this process over 6 years back. We've had over 600 virtual tumor boards which have been run so far. We do this at least thrice a week now. We do it on a Saturday when most clinicians are relatively free. And at any given point of time, between 15 to 40 of the NCG centers log online, share their clinical situations, and get the expert opinions from anywhere from 110 to 150 oncologists from these 15 to 40 centers who log on. So while we initially started this as a patient-centric initiative, trying to address complex cancer situations for individual cancer patients, what we didn't realize, and to our pleasant surprise happened, was that this is a phenomenal way of continuing medical education for our physicians. So people who are in the less experienced, the smaller centers, by virtue of participating in these meetings and learning and listening to experts who are site specific, were able to gain a lot of knowledge and skills about how to manage these patients. And this was something unexpected, but fairly good. Leveraging the fact that we are a large group, we negotiated with journal publishers and worked with them in reducing costs of subscriptions to medical journals. This is one of the largest drains on academic centers' budgets, the high cost of subscribing to medical journals. But what we were able to do by negotiating with publishers as a group was to get discounts to the range of 90%. So effectively, an individual center would need to pay just 10% of what they would otherwise have had to do if they were to subscribe to these journals by themselves. We also leverage the fact that we have multiple academic centers which by themselves have subscriptions to journals and books. So we created a discovery tool wherein the library resources of these cancer centers are aggregated into a centrally indexed platform, and member centers who want a particular resource can just put it online, and the relevant library would supply the resource to them within a day. So again, democratizing the access to cutting edge advances in medical technology. We started a relatively ambitious program of massive open online courses. I mean, you would know, I would be the last person to suggest that this would be in the scale of many of the other well-known MOOCs, but nevertheless, we made a start. We have online facilities where continuing medical education is available. We have several aspects starting from cancer research methods to individual cancer treatment and so on. And this is again offered completely free of cost to member centers as well as their participating physicians. So we were faced with this unique problem of a very large proportion of the Northeast being geographically less accessible to the other parts of India, and even places like Calcutta, which are relatively close, take anywhere from a day to 2 days to travel. And the result was that many of the oncologists and people treating cancer in these parts of the country did not get access to continuing medical education. So rather than expect them to come to major cities like Mumbai, Delhi, and Calcutta, what we did was to flip the system around, and we created what we call a traveling school, and we experimented with pathology to start with because it's the fundamental basis of cancer diagnosis, where we sent a group of experts from the National Cancer Grid across 11 cities in the Northeast. And as you can see, most parts of the Northeast getting covered in 2 cycles. And what they did is nothing short of remarkable, because they would do a workshop on how to gross pathology, how to report pathology, a full day workshop, then move to the next city, which could take a full day, then go on to the next workshop, and so on. And we did this over 2 cycles, the first cycle lasting 15 days and the second cycle lasting 11 days, where we covered most major cities in the Northeast and brought continuing medical education to the doorsteps of these oncologists. Again, learning from our experience with negotiating with industry for drugs, for journals, we embarked on group negotiation for cancer drugs. So what we did was to aggregate demand from multiple centers, pooled the requirements as far as volumes of high value drugs were concerned. We went through a central tendering and negotiation process, again hosted by the Tata Memorial, which meant that everything was as per Government of India norms. And final contracts were, however, signed between these individual centers and pharma companies, thereby offering the benefit of high volume group negotiation to much smaller centers, which otherwise would not have been able to get this. And the kind of discounts that we got range from anywhere from 20% discounts for patented drugs where there was a monopoly, to discounts as high as 80% for some of the generic drugs. And we are hoping that this brings down the cost of cancer care substantially in the country. Again, serendipitously, one of our early asks from the centers was to be able to create a situation where we were able to aggregate data from across these centers. The fact that we are a large group of cancer centers meant that if we were to aggregate data, that would be a huge resource. But unfortunately, we were faced with a lot of problems initially, and which we've still not overcome. One of them being that many of these centers did not have electronic health records. They still depended on paper records, which meant aggregation was a big challenge. And even amongst the centers which had electronic health records, the fact that these systems did not talk to each other meant that we needed to look at different solutions for aggregating this data. And what we did was to have a hackathon of tech folks and medical cancer treating physicians at Bangalore, where we looked at trying to identify what were the biggest challenges in data and tech as it related to cancer care. And one of our first proof of concept efforts that we did in collaboration with this voluntary organization called iSpirit, which many of you in the computer sciences field might be well aware of. They are the folks who created Aadhaar, the India Health Stack, and the India Stack, and so on. And working with them, we created a proof of concept where, with a very robust consent manager, which can be hosted by anybody, with patient consent being OTP based, we were able to demonstrate that 3 different cancer centers in India with 3 very different electronic health records could aggregate their data, not in a very systematic way, but nevertheless could bring the data together. And again, though we did do this as an effort for cancer care, when the National Digital Health Mission was launched by the Prime Minister and they needed to do it under very tight timelines, this ready proof of concept has now been adopted by the ABDM as something which is a very crucial part of their entire effort of digital health and electronic health records within the NHA. I've spoken a lot about successes, but I would be remiss if I didn't mention about things that didn't work. We have several spectacular failures. As I mentioned, one of our earliest asks was data aggregation and high-speed digital connectivity. We made some progress there, but not as fast as we would have liked it to be. We had prioritized health promotion and communication, especially with public education, because screening in a country like India, the logistics are tremendous, and we thought improving awareness amongst the general public would be a better strategy, but we haven't made as much progress as we would have liked it to be. We wanted to have a national cancer biobank which was geographically diverse, ethnically diverse, but again, this is work in progress. We are in talks with the Department of Biotechnology to see whether they are interested in funding this. And while we were very successful for group negotiations with drugs as well as with journals, we were not nearly as successful with equipment because cartelization and physician preference for minor differences in equipment specifications stood in our way, and we've not really made the kind of impact that we've been able to do with drugs and with journals. I'll move on from patient care to a couple of other areas which I'll speak briefly about. As I mentioned, collaborative cancer research is at one of the pillars on which the Cancer Grid was founded. We also fund clinical research studies and translational research studies, provided these criteria are met. We insist on multicentric, multidisciplinary collaborations. We do not fund single center studies, even if you are at Tata Memorial. The cancer that is being studied has to be either common or unique to India, so that esoteric cancers, which are extremely rare, not to undermine the unmet need in these cancers, but if you have to prioritize, you need to look at problems which are specific to India. We have a strong emphasis on cost effectiveness, which means that if the research proves an intervention to be effective, implementation due to cost constraints is not necessarily a hurdle. So we emphasize that interventions need to be cost effective. Researchers who get funded by the Cancer Grid have to commit to share their data in the public domain, making it open for other researchers to mine the same data and come up with newer findings. And we have a very strong emphasis on public and patient involvement in the efforts that we fund. More recently, we have made more systematic efforts at identifying gaps in evidence, again, leading out of the resource stratified guidelines effort, because while we developed these guidelines, we realized that there were several gaps in evidence, and we are looking at systematically addressing these gaps, and we call this the National Cancer Research Initiative. So any of you who dealt with a physician or a researcher in Tata Memorial will realize that they are extremely pressed for time. So we created a clinical trials unit and a academic contract research organization to help researchers with the nuts and bolts of doing studies, trying to make it as pain-free as possible for researchers so that they could focus on the science and not on the logistics. So what the CTU and the CRO do are to help researchers with study designs, with biostatistics, with regulatory submissions, contracts, insurance and multicentric studies, and actually monitoring and evaluation of ongoing clinical studies. Undergraduate and postgraduate medical education has virtually no training in research methods. So this was a gap that we needed to address if we were to make any headway with the research enterprise in cancer in the country. So we started this workshop, which is modeled on just 3 other similar workshops worldwide. There's just the other 3 being in Vail at California, one at Zeist in Netherlands, and the third in Sydney in Australia. This is the first of its kind in any low middle income country. And just to give you a brief idea of what this workshop does, researchers from across the country and increasingly across the world apply to participate in this workshop with a 1-page research concept idea, which is some very vague idea at the back of their mind. And with a competitive process, the participants are selected and they enter into this very intensive 6-day residential workshop in a learning academy just off Lonavala, where participants frequently spend anywhere from 12 to 18 hours per day working on their protocol, and at the end of 6 very intensive days convert this 1-page summary into a full-fledged research protocol which is ready for ethics submission. We have a very high faculty to participant ratio. So typically a workshop would have 64 participants divided into 8 groups, smaller groups, so that it enhances the ability to have one-on-one mentoring and training. And for these 64 faculty, we have 64 participants, we have 35 faculty. So very high faculty to participant ratio, which I think is key to success. Based on feedback from the Credo workshop participants, we also started this effort of continuing to mentor these early career researchers through virtual research boards, very similar to our virtual tumor boards, but this time focusing on helping researchers with specific problems that they might have even after they passed out of the workshop. We've been collaborating with the Department of Biotechnology, where we signed an MOU some time back in working towards jointly collaborating on training in research methods, as well as with funding clinical and translational cancer research in the country. I've already mentioned to you about our collaboration with Ayushman Bharat, with whom we've also signed an MOU. And in addition to linking our resource stratified guidelines to the Ayushman Bharat reimbursement, we are also working with them in having rational work packages for the various cancer treatments that are available. Based on the feedback from the member centers and the relative successes that we've had in the very early stage of our evolution, we were approached by several countries from across the world, from predominantly other low middle income countries in Asia and Africa and Latin America, who wanted to share our resources with them. And a couple of years back, we launched the Global Cancer Care Connect, which is a global wing of the National Cancer Grid, if you want to call it that. And again, this is something that has been extremely helpful for several countries. So these are some of our future steps. As I mentioned, integrated data collection and aggregation is still work in progress, though we made some initial progressive steps. We are nowhere close to where we want to be. We are in the process of getting funding for a rare cancer registry and an exceptional responder registry, so which serves as a data bank as well as a tissue bank for these extraordinary areas from which cancer biology can be learned to a large extent. But again, this is something that is for the future and not something that we have in place right now. The group negotiation for drugs is well in place, but equipment is a nut that we still have to crack. And as I mentioned, a longer term plan for health technology assessment, which will guide in a more robust way our efforts at making sure that we provide value-based cancer care for our patients. So as I mentioned at the beginning of my talk, we had several barriers and hurdles, but we were able to have workarounds around them. I think the reasons we were able to find these workarounds was that we have a very flat structure with no hierarchy. And it's though it might sound cliched, most of these initiatives which I mentioned over the last few minutes have actually come from some of the smaller centers, because they were the ones who were likely to benefit the most, and they were the ones who came up with these ideas which we were ready to implement. And I think, as I've showed, we made several mistakes. Not everything that we worked on was successful. However, we do realize that if we don't take the first steps forward, you might not make mistakes, but you might not make any headway either. And I think in several ways, we've been able to bring value to our member centers. And I think this has been one of the key reasons why the NCG has been as successful as we have been. But most importantly, I would emphasize that we've had this very strong sense of collaboration. We strongly believe that the whole is greater than the sum of the parts, and therefore we have worked on that philosophy. An effort of this nature would not be possible without the unstinting support we've had from several national and international organizations, some of whom are listed here. The Department of Atomic Energy for funding us, the Tata Trust, which helped us to a large extent, and several international organizations like ASCO, Cancer Research UK, the Medical Research Council in the United Kingdom, and the King's College London, just to name a few. And I liken this to a Formula One pit stop. So while most of us focus on the high speeds that these cars achieve, the sheer expertise and the skill of the driver, what we should understand is that there's a huge team behind them. And if you see these people, each of whom ensures that a pit stop happens in a time ranging between 1.8 seconds and 2.8 seconds, within which 4 tires are changed. And earlier fuel used to get filled. And what we don't realize is that the difference between a winner and someone who comes second place is the difference between 2.8 seconds and 1.8 seconds. And this is an aphorism that we will live, we really lived the cancer grid through. Came from a famous American president. It's amazing what you can accomplish if you do not care who gets the credit. And to a large extent, the National Cancer Grid has worked on that philosophy. So I started by saying that we were 17 centers, most of them skeptical directors of these centers who came in for our first meeting in August 2012. And today we have grown to over 260 centers, which between them treat 750,000 new patients with cancer annually. And just to give you context, this translates into 60% of all of India's cancer burden. So I'll stop with that, and I'm happy to take any questions.
Thank you, Dr. Pramesh, for an excellent presentation.
So let me try and unshare my screen. Somehow yeah.
Anyone who would like to ask questions could just raise hands and you'd be, we'll just unmute you. So as I wait for others to raise their hands, Dr. Pramesh, I have some question for you. It was actually very assuring to see how uh, equitable healthcare you try to ensure by benefiting different stakeholders, patients for sure by design, but also physician, making it possible to do evidence-based, basically decision support. Also was very impressive to see how you got, you know, pharma and the connection between hospitals and pharma through the power of negotiation. Of course, there are some hurdles to cross, which you pointed out, but yet you've gone a long distance. What I'm wondering from a research perspective, the research community is, that there are these long drawn processes where you seek ethics committee clearance, where there are multiple layers, and it's important to have the due diligence done. Did you have any experience of how the multiple layers, the delays often incurred in this ethics committee clearance could be reduced? And specifically also, if like some of the data which is the cat lab data, all that is digitized, there are standard, but path lab still, we have a long way to go. How did you bridge that gap when it comes to clinical research? So this is my broad question.
Right. So ethics approvals do sometimes take time, but as all of us realize, they're there for a very good reason. And the fact that above everything else, patient rights and privileges need to be safeguarded. And while we might live in a world where there are several other countries which have this system of central ethics committees, which means that for a study which is running in 20 centers, all you would need is a central ethics committee, one ethics committee to approve it, and the 20 centers could implement it. This is not something that is yet common or popular in India. As of 2 years back, this possibility didn't exist. But the ICMR has recently come up with this concept of centralized ethics committees to approve studies, but they're just rolling it out very slowly, and not many ethics committees are yet approved to do this on behalf of the other centers. But having said that, and having been on both sides of the ethics committee debate, I've been an ethics committee member as well as I've at other points been a researcher myself. I must say that a lot of some substantial part of the delays do happen because of lack of time for the researcher in delays in responding to ethics committee queries, rather than it being entirely the ethics committee's being finicky about the kind of study. So I think we need to be cognizant of that. But what we've done is, for example, at Tata Memorial, when we realized that the existing centers existing ethics committees were inadequate to deal with the large number of studies, we multiplied them. So instead of one ethics committee, which we had 10 years back, we currently have three. So three committees meeting once a month means there are 3 meetings every month, which has reduced our turnaround time for ethics approvals quite remarkably.
So what was the role that the National Cancer Grid could play in reducing that turnaround time? That was basically my question here.
So the short answer is we haven't been able to do it yet. So we are in talks with the ICMR to recognize at least some of the accredited ethics committees within the National Cancer Grid centers to become central ethics committees. And if the ICMR agrees to that, then we will be, to a large extent, be able to cut short the time for ethics approvals.
Thanks, Dr. Pramesh. Rizwan, like to go next?
Sure. Yeah, thanks, Dr. Pramesh. This was a very, very insightful presentation, and the journey over the last 10 years is quite fascinating. We have a lot of faculty from IIT Bombay on the call here, and clearly there's been a lot of interaction between the new Center for Digital Health and Tata Memorial. Given the fact that we have a great audience here, how would you think about potential opportunities for collaborating between IIT Bombay in general, but the center in particular when it comes to the National Cancer Grid there?
Right. That's a great question, Rizwan, and I don't think I have a simple, straightforward answer to that. To this, as you might imagine, a lot of collaborations happen based on personal equations rather than a systematic mechanism for promoting these. Having said that, there is merit in attempting a more systematic effort at creating relationships. I know that Betik in IIT does this really well by having these hackathons where you just put a bunch of people from varying diverse groups together, even by a pick of chance. And it's been remarkable how they've been able to establish these teams and in some situations actually create long-term relationships which have stood the test of time. So that's something that we could certainly think about between IIT and Tata Memorial, certainly, but even with the National Cancer Grid on a larger scale. And we have a really robust mechanism of disseminating this. So our annual meetings are attended by over 90% of the leadership of these 260 odd cancer centers, which means that something that's discussed there, something that we are likely to create and share with them would very rapidly disseminate down to the ground researchers within these centers. So that's something that we could certainly think about, but also have smaller, let's say, brainstorming sessions where we look at specific areas of digital health where folks from KCDH, from IIT Bombay, as well as the NCG get on to calls, trying to find, I mean, we'll virtually be a matchmaking ceremony by itself and trying to get the right people to talk to each other. But it's a bigger challenge than what I've just described. It's easier said than done, but certainly something that we should work upon.
Thanks.
Professor Preeta Pant, would you like to go next? You can unmute yourself, Professor Preeta. Professor Preeta, you're not able to unmute yourself. Nirmal?
Okay, now can you hear me?
Yeah,
Okay.
yes.
Sorry. My question was not really research related, but about the whole idea of the grid, to be able to reach out to people who would not be able to access the kind of facilities that Tata Memorial has to offer. So thinking that people who are at the lower end of the socio-economic educational spectrum would also probably be the ones who would delay seeking treatment. Is there also a thought for some kind of an outreach just to make people aware? I understand that that's a huge burden probably, but is that also part of the plan at some level to make people aware that, look, the sooner you do it, the better it will be for you?
Sure, that's a really nice, a good question, and it comes to the heart of why there are delayed diagnoses in India. So a cancer diagnosis in India has several problems to it. One, there is this immediate association of cancer with certain death. I mean, the fact that a large number of cancers are actually curable with long-term survival rates in the range of 90%. Some of them obviously don't do so well, but that's not yet known to the vast majority of India's population. Cancer diagnosis, even today, even amongst the most educated, strikes a chord of fear, and that's something that we need to dispel. The second part of it is actually the lack of access to quality centers, which we are trying to address to the NCG. And as I mentioned, health promotion and awareness was something that was very high on our priority list, but unfortunately, it's not been one of our success stories. And this is to do with the complexities of messaging. So while there is a lot of publicity given to those gory images of tumors in cigarette packs, there is actually a line of thought which says that if you show them to be too gory, people just switch off and they just don't, they completely are in denial about these kind of things. So the complexities of messaging and the logistics of effective messaging, in spite of today's world, which is so connected and which is so social media dependent, has turned out to be a bit of a problem, but it's still something that we are hoping that we will be able to address in the near future. clearly awareness is something that we need to work upon, both with dispelling the myths of cancer, that something that you mentioned just now, that just providing the information that if you come at an early stage, you are much better chance of getting a cure than others, and not just a higher chance of cure, you spend lower getting a curative early treatment for early cancer than just gaining a few months of life for advanced metastatic cancer. So from all perspectives, it makes sound sense from a health perspective as well as an economic perspective to catch them early and treat them early.
Thanks, Dr. Pramesh. Nirmal, would you like to speak here? You have a question, and you can unmute yourself.
Thank you, Dr. Pramesh, for the very nice talk. So I have a question. It has two parts basically. So when you mentioned like you have the meeting with the different centers of the NCD grid where you are discussing various cases. So do you also have a system where like, okay, once the patient is cured or whatever is once at the end of the treatment, the data can be shared like a case study with the other doctors. Okay, this is what was the case. This is how it was diagnosed. This is what we did. That's the first part. And second part is right from the point of view of like maybe something like a retrospective clinical trial. So is there by you can say by protecting the patient identifiers, can the data be used? Like, is there some provision over it?
Right. So these virtual tumor boards where we discuss these, so we've been very focused on trying to see what impact we have with each of these initiatives. But with some of these, the logistics of demonstrating impact have been quite overwhelming. And this is one example of that. So when we started the virtual tumor boards, we wanted longitudinal follow-up on all of these patients who were discussed within the tumor board, just to see what their outcomes were, how often the decision taken in the virtual tumor board were actually implemented by the concerned physician or the concerned cancer center. But the fact that each meeting doesn't have the same set of people joining in, the fact that at the time we started this, we did not have the administrative support to be able to follow up with these cancer centers or treating physicians meant that we do not have longitudinal follow-up on patients discussed within the virtual tumor board. We are in the process of addressing that, and also the fact that something that you mentioned, that it being a great educational resource, we are doing that with the expert opinion service. So the expert opinion service, fortunately, everything is online. Except the outcomes again, which we don't track there, but the treatment decision at least is online, which means that this is a ready resource for training young oncologists who are then offered this opportunity to get into hundreds of, if not thousands of clinical situations, go through what the evidence says, think through how the expert provided an opinion, and learn from all of this. And we are in the process of curating these huge data sets of clinical patient data into doing that. But as I mentioned, this is not a systematic collection of data wherein you can use this for real world evidence. But what I mentioned in my future steps slide, the ability to aggregate the data, and clearly this is not a problem that we have solved so far. And not solved for two reasons. One, the low uptake of electronic health records, and second, the current inability to aggregate data from disparate electronic health records.
Okay, thank you.
Thanks, Dr. Pramesh. We had one question from Gulam. I think he was here, and then Gulam, would you like to ask a question? You can unmute yourself.
Yeah. Am I audible?
Yes.
So thank you for the interesting talk. My question was it is related to the hitman that you shown in the very beginning. So I wanted to ask with the establishment of NCG and the establishment of more and more data centers, has this heat map changed over the period of time? Means that is like 40% used to come out, like more than 40%, 60% used to come out from the outside Maharashtra. So what is the scenario now? So how has that? So that's I'm curious about that.
Right. So this is really interesting. So when we started the Varanasi Center, the Tata Memorial itself started this center at Varanasi, which is a fairly large center. We have a 540 bedded facility in 2 centers there. And on an average, we get between 3,500 to 3,800 patients in and around Varanasi visiting the Tata Memorial at Mumbai. So when we looked at the districts of Azamgarh, Jaunpur, and the local area, we were getting 3,500 to 4,000 patients to 3,800 patients coming here. We looked at what the impact of this had been after the Varanasi Center turned up. And just to give you context, Varanasi registered 16,000 new patients in the second year of its existence. In 2020, though it was a pandemic year, we had 16,000 patients, new patients getting registered. But when we looked at the number of patients coming in from those districts to Mumbai, they had just reduced by just 600 patients, which meant that either these 16,000 patients were never accessing any care, or they were getting care at some smaller center, which clearly they did not prefer as compared to Tata Memorial. But the short answer to your question is that I think the need is so high that I think more than starting just new cancer centers, we will need a very different approach to ensuring that patients don't have to travel long distance for care.
Thanks, Dr. Pramesh. Neeraj Trivedi had a question. Neeraj, you could speak. Neeraj, could you unmute yourself and ask? Your hand is raised.
Yes. So am I audible now?
Yes, you are.
Yes, sir. Firstly, really, this was extremely informative, and I'm just delighted that such a thing is happening at a national scale. My question is, I think, so I'm a cancer survivor, and we have a, kind of a support unit for bone marrow transplant support group in the country. The question is, I think cancer is just much more than the treatment itself. Post-cancer, there is an entire rehabilitation phase of nutrition, diet, physiotherapy, fitness, all of that. So what is that level of engagement currently at National Grid to view this? Because you have 266 centers across, which could really prove a boon for people who are seeking rehabilitation post-cancer treatment. So are there plans for National Grid to kind of look at this in depth?
You're absolutely spot on. So when we typically speak to directors of cancer centers and ask them what their priorities for their centers are, you typically get a response of we need more operation theaters, we need more surgeons, we need more medical oncologists, we need more radiation equipment and radiation oncologists. What is very often neglected to a large extent is these allied areas, which are equally, if not more important than the three areas that I mentioned of surgery, chemotherapy, and radiation. These are areas like palliative care, physiotherapy, occupational therapy, stoma clinics for people who have stomas, central venous access device clinics. So a lot of which goes into the periphery, what is considered the periphery of cancer care, but to a patient probably matters much more than a scan showing a tumor shrinkage from 5 centimeters to 3 centimeters. What really matters to patient is how are my symptoms getting better? What kind of a support system do I have? And unfortunately, there is no, these are not prioritized. But right from the beginning, we have had a strong advocacy to start palliative care clinics in every single cancer center that is part of the National Cancer Grid. Some of them do have challenges by way of financials as well as resources, as human resources, but there has been an encouraging move in that respect, that more cancer centers are now opening up palliative care clinics within their centers. When it comes to areas like the other areas, oncology, nursing, physiotherapy, occupational therapy, we have a training system in place where by a blended learning module, we have a mixed learning, partly online, partly in person, where any center which wants to expand its scope. So what we started doing is to multitask. So just last week, we had a group of nurses coming in from a small cancer center in Silchar in Assam to Tata Memorial for a period of 1 month to learn psycho-oncology. Psycho-oncology, if you ask a cancer center director, is probably not prioritized very high. But this way of multitasking by getting nurses to fulfill the function of a counselor another nurse came in with for training in palliative care. So these kind of task shifting and task upskilling are things that we are already working on. But again, plenty of scope to scale up.
Thank you, Dr. Pramesh. I don't see any other raised hands. Thanks, Neeraj, for that excellent question. With that, probably we'll again extend our heartiest gratitude to Dr. Pramesh for orienting the Koita Center for Digital Health into this digital health space. I think the talk was extremely well presented. Thanks, Dr. Pramesh. You were very inclusive. You also presented the challenges so that both the student and faculty community alike feels motivated to try and contribute to this important initiative. And I also feel the talk is extremely well timed because we have the state joint directors ABDM induction training program to be conducted in collaboration with the National Health Authority starting tomorrow and will conclude day after tomorrow at IT Bombay. And thanks for getting us oriented there. We look forward to very close interactions with you, specifically on the National Cancer Grid, but also more generally, where many of you might be aware, Tata Memorial Hospital forms a very strong digital health partner with the Koita Center for Digital Health. Besides, of course, Dr. Pramesh being on its advisory board. So look forward to working further with you and hope many more inspired minds feel motivated to contribute to this very important initiative. Thanks, Dr. Pramesh.
Thank you very much, Professor Ganesh, and it's been a real pleasure being part of this and the discussions after the talk. So thank you very much for inviting me for this. Thank you. Bye.
Thanks everyone for joining also.
Yeah.